How you doing? Good evening, America. Welcome to Pensacola, Florida. I am Dr. Randy Fink, and this is Fertility with Fink. It is great to see you here on this Tuesday evening, as always. So, previously, we were doing 4 o'clock p.m. Eastern time. And so this is our first time going here to 5 o'clock because it looks like this is really probably the better time. 5 o'clock Central time, if I misspoke there, which means 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West. And you are in the right place to talk about fertility and all things that are women's health. I am I'm a fertility gynecologist here at New Life Fertility in Pensacola, Florida. That is a part of the First Fertility Network, which is a wonderful place. A wonderful place indeed. And I'll tell you what, we've got the chance to ask you to answer a whole bunch of your questions tonight. Looks like one of my feeds may be frozen there, but we've got Facebook, we've got LinkedIn, we've got YouTube right there in the middle. We've got a couple of different Instagram feeds here. Here's mine. It's Randy Fink MD. And then there is New Life Fertility's Instagram page, which is right here. And I think that's the one that seems to be glitching. But ask your questions right here. I'll be delighted to answer them. We also have a website, or rather an email address at which you can pose your questions, because sometimes it's hard for us to be able to get to all the questions we have on the program here. And that is Ask Fertility with Fink at firstfertility.com. Ask Fertility with Fink at firstfertility.com. And I will be happy to try to get to answer those questions. Meanwhile, let's say hi to some of our friends. Mary June, thanks for being here, and Olivia. Also, we've got Kate Balky, it looks like. CCAKA Pinky, hi to Heather. Madison Thorne, it looks like. We've got Tony, we've got Julep, we've got Lynn Hassett. If you're really watching, well, hello to you, my old friend from the Keys. Little Jax, hey, nice to see you. Thanks for being here. Hi, Mariah Wagner. And we've got some friends who have joined us over on the Facebook side, but haven't identified themselves yet. Hey, how's your week been? Tuesday is always a really interesting day, mostly because it's not Monday anymore, which I think is a big plus, and we've got the whole week laid out ahead of us. I think Tuesday kind of strikes me as a day with a little bit of optimism. It's an optimism for things to come, and that's good, Coming up, by the way, if you're not aware, next week is National Infertility Awareness Week. So you'll see folks wearing orange in honor of National Infertility Awareness Week. I'm not sure what the significance of orange actually is, but you'll see a lot of programming. We're going to be doing a lot of content during the week. I will also next week be live from Tulsa, Oklahoma, where I will be working with my colleagues at the Missouri Center for Reproductive Medicine. That's MCRM. So our live will be from there, but we'll still have a chance to answer all your questions, as well as to take a look at the email questions that you have for us at askfertilitywithfink at firstfertility.com. So let's jump right to those because we do have a couple of questions here that pose some really interesting things. First comes from Jessica, and Jessica asks, what's the optimal DHEA range for fertility? So Jessica has been taking 25 milligrams of DHEA 3 times a day. The levels were checked, and the level is 503. And so she wants to know, is that too high? And if it's too high, how to get it down? Well, the easy way to get it down is to just simply stop taking the DHEA. So here's the deal on DHEA. DHEA is a very important, is a hormone that comes from the adrenal gland and is an intermediary between estrogen, or between testosterone and estrogen. And it is probably one of the more important supplements, in my opinion, to be taking for women who have either a diminished ovarian reserve or those who have proven themselves to not be great responders to IVF medication. DHEA it has been shown at that dose, which is 25 milligrams 3 times a day, to be helpful and to be beneficial. Now, there are many clinics in the United States that say everybody needs to be on DHEA, and at the same time, there are also many clinics that say, no, that's too controversial. We don't want to go there. And I will tell you that there are some studies that have shown us that DHEA isn't helpful, but there are plenty of other studies that shown it is. People who are critical of DHEA will say, well, there's no real good randomized controlled trials, which are the kind of the gold standard for determining science, medical science. And these things are very hard to study. So it's not reasonable to think that there should be a randomized controlled trial on everything that we want to use. DHEA is one of those things, a lot of studies looking at DHEA, and I do feel like for women with diminished ovarian reserve or people who are poor responders, that 25 milligrams 3 times a day is the correct dose. Now, when you check the blood test that you're testing is called DHEAS. That's what it looks like in the blood. And it is not uncommon to find that the level gets high, like yours was 500 here, Jessica, and I would say that's completely fine. If it gets to be, in the 700 range, I'd say, well, you know what, that's probably not the best place for it to be, because that's getting to be a little bit high. We are looking at supraphysiologic levels, which means levels that are higher, slightly higher than what you might find in physiology. And I will say that the DHEA is not something that I want someone who has polycystic ovarian syndrome to be taking, because their own levels of DHEA tend to be a little higher anyway. So does it matter what your DHEAS blood test shows you? And the answer to that is no. I'm very comfortable with it, Jessica, being at in the 500 range, because you're taking it for a reason. You're trying to bolster up on it. Now, and some people say that DHEA is actually a life hack, that in the anti-aging community, it may help you to stay alive longer. So as far as doing it for egg quality with IVF, I don't see any problem with doing that short term, even if it keeps your level a little bit high. Now, the most common side effect that folks have from taking DHEA is that they can get a little acne. They can, because it can become like a testosterone, which most commonly would present as acne or a little bit oilier skin. Sometimes people's sex drive goes up as a result, or sometimes people's energy level is increased, which isn't such a bad side effect to have anyway. But just started to have some night sweats and spotting after a month of being on it. The spotting part I can understand, because ultimately it may be metabolized as some estrogen, which can cause a little excess, some extra growth in the lining, which can present itself as spotting. But the night sweats, so actually the most common reason that folks have night sweats, you'd say, oh gosh, that must be my estrogen, right? No. Estrogen deficiency, once we get to menopause, causes us to have hot flashes. And a hot flash is like, I call it a power surge. It's where it's almost like literally someone is lighting a fire from the inside. And what's happening there is that the blood vessels are spontaneously dilating. And when they open up like that, blood rushes to the skin. And since blood flow is actually what we'll call a thermoregulatory mechanism, it's something that helps us to maintain our temperature, we are rapidly getting rid of heat, and that is sensed as a hot flash. But night sweats are usually as a result, most commonly as a result of testosterone deficiency. So it may be that in your case, Jessica, you were metabolizing a little more into estrogen than you were into testosterone, and that was shifting your balance away from testosterone. It's possible, but night sweat's actually an androgen deficiency more than an excess. But to answer your question, diminished ovarian reserve um, um, or history of being a poor responder to the IVF medications, 25 milligrams of DHEA 3 times daily. Got another question here. Thank you, Jessica, for emailing in your question there. And if you have a question, feel free to ask it right here live, and we'll get to it if we can. Otherwise, be my guest to email that to us, and we will have a list in advance of questions, and that's Ask Fertility with Fink at firstfertility.com. This comes from Amber. And Amber says, I guess this is in response to something that we were talking about last week, which was some of the interventions that we can do for folks who have had unsuccessful transfers before. Now, I will tell you, in the business, those are called failed transfers, and I don't like to think of it as a failure because it's really not. Every time you do an embryo transfer and you don't get pregnant, and for that matter, even if you're not doing IVF, even if you are doing something like IUI, every time you do a cycle and it doesn't result in a pregnancy, I don't believe that's a failure because we have learned something about you. We learn something about you every time we do a cycle. So everything we do is valuable. So when you don't get pregnant, well, it's not the desired outcome, but it's not a failure. So Amber asks, could I request to assume the worst and get treated that way, as in using everything that you have in terms of the immune system in order to try to prevent an implantation from not happening. I have PCOS. I've done 1 retrieval and 2 transfers so far with no luck. We did a laparoscopy. No endometriosis. I got 42 eggs at retrieval. I have 3 embryos. We tested sperm. I didn't do PGT testing because it seemed like an extra expense. I'm looking for anything to cut costs this time without sacrificing what's necessary. It's been a lot on my body. I thought about opting out here and taking a break, but I want to give it all to make my chances successful. So when you're doing embryo transfers and they're not working, there's a lot of things to look at. So first of all, we know that when we have a euploid embryo or a tested embryo, that embryo has a 65% probability of being able to get you a baby. What gets to be the most frustrating for us is when you transfer a euploid embryo and it doesn't stick. And people say, but why not? Why didn't it work? And the answer is, well, 65% is not 100%. By the time you do your second embryo transfer, you are at about an 83% probability of pregnancy, and then a 95% probability of pregnancy by the time you do your third. So the evidence shows us that if you just keep doing transfers, then eventually it will probably work. The problem is, who wants to just keep doing transfers without knowing that you are changing something, that you want to do something different? Because they say the definition of insanity is doing the same thing again without changing anything and expecting a different outcome. Well, that's not always true in the infertility world, because you can do one cycle and have one outcome and then repeat the same thing in the next cycle and have a completely different outcome for no explicable reason. So, I would say it's hard to compare these two things. It's hard to say from one to the next. But the first thing I'd want to look at, Amber, is what kind of embryo transfer are you using? So there's a medicated cycle and there's a fresh or a modified natural. I'm sorry, I don't mean fresh. I mean a natural or a modified natural cycle and a medicated cycle. In a modified natural cycle, we're giving you some ovulation induction. We are inviting your ovaries to create a follicle to release an egg. And when you do that, you make your own hormones. You make your own estrogen. You make your own progesterone. There seems to be some advantage to doing that. Your own progesterone is probably where the magic comes in using a natural cycle. In a natural cycle, you don't do ovulation induction. You just ovulate on your own anyway. Some evidence shows us it's a little better to do it with ovulation induction. So if we do that, you release an egg, you make your own hormones, and then we place the embryo back inside of you, and you have really provided everything that your body needs for that pregnancy to stick. In a medicated cycle, the medicated cycle is where we are giving you all of that hormone. We're giving you the estrogen. We're giving you the progesterone in the form of the progesterone in oil shot is really the best thing to do. Some people will say, well, I don't really want to do the shot. Can I just do vaginal progesterone? And the answer there is that the outcomes are not nearly as good if you don't use the progesterone in oil. There's some programs where that progesterone in oil, also called PIO shot, is done on a daily basis. There's some evidence to show that you can do it once every 3 days. In fact, that's what we do here at New Life on our medicated cycles. And that is you supplement it with some vaginal progesterone, but really once every 3 days ought to be sufficient for most people. So there's an option for you as well. If you have been doing medicated cycles, Amber, and it didn't work, then I would say maybe consider doing the other type of cycle. Now, the evidence shows that one is not any better than the other, that a natural or a modified natural cycle is at least as good as a what we call programmed cycle or a medicated cycle. At least as good, but there are some studies that show it might even be better. There may be a lower miscarriage rate. There may be a higher ongoing pregnancy rate. And if that's the case, and you've been doing medicated cycles, time to think about switching it up. The other thing has to do with the immune medications. Now, depending on where you are, there are some programs that will routinely prescribe you an immune protocol for everything that you do, irrespective of what we know you have. And the thinking there is, well, you can do a lot of very expensive testing to try to figure out if you have something, or you can just take the medication. I am not of the belief that everyone needs a full immune protocol. Is there harm to doing a full immune protocol and using everything that we know how to use in every single person, irrespective of the reason? Is there harm to that? Well, it's hard to say. There might be in some people. Some of these medications are not, completely benign. Prednisone, which is a steroid, sometimes people get on prednisone and they will stay on this prednisone for months on end because they forget to take them off of it. And that's a problem. It can have some very deleterious effects on your weight, on your blood pressure, on your bones, on your blood sugar. So, I would say, in a guarded fashion, the things that we look at for immune is number one, some steroids, some prednisone. We talked last week, Amber, about tacrolimus. Tacrolimus, also known as Prograf, is the medication of choice in someone who has recurrent implantation failure. There's some very good evidence using tacrolimus, and I personally am a very big fan. There is a test that you can do to see if you need to be taking tacrolimus, but I believe the test costs about $2,800, whereas the medication costs about $4. So it's much easier for you just to go ahead and take the medication. It's a safe medication to take. It's a short-term medication. So the only real contraindication is if you have had some history of what we call a lymphoproliferative disorder, which means something like a lymphoma or some type of blood cancer, then we really might say maybe that's not the best choice for you. A baby aspirin Makes all the sense in the world. Sometimes we'll use some Lovenox or blood thinner, which helps the blood flow going to the uterus. And it's easy enough to use an antihistamine like Claritin or Benadryl, along with some Pepsid. Now, why would you use Pepsid, famotidine? Pepsid is a medication that is, used to treat people with acid reflux. And you might say, well, I don't have acid reflux. Are you afraid I'm going to get acid reflux? And that's why I should be taking Pepsid. There's some studies that show better pregnancy outcomes when the pH of the stomach, when the acidity of the stomach, when it is not as acidic, which means it raises the pH a little bit. Stomach acid may have some downstream effect on the body's ability to get pregnant. And while this is certainly deserving of more study, it's pretty easy to use Pepsid because Pepsid now is over the counter. It used to be, when that medicine first came out, it was a prescription. Now you go into Walgreens and you just buy it over the counter. There's generics. There's the Walgreens brand even. So it actually gets pretty easy there. So would you do all those things, Amber? I would say certainly after your 2 unsuccessful transfers, I start to think, yep, what are all the stops that we want to pull out to make sure that we're not missing something? The other thing that we really think about in this scenario is something that you have already addressed, and that is endometriosis. So endometriosis is the process whereby the lining of the uterus that normally sloughs off when you have a period instead works its way up to the inside and implants within the pelvis. It interferes with the way the brain talks to the uterus, so much so that it can significantly inhibit an embryo from being able to implant. So if you have endometriosis, that may be one reason why these embryos aren't sticking. Used to be that you had to have a surgery in order to determine if you have endometriosis. We can now diagnose endometriosis without surgery, and that's through a test that's known as Receptiva. Receptiva is an endometrial biopsy. It's a little straw that goes inside the uterus, sucks out a little piece of tissue, and can be tested for a marker that's known as BCL6. BCL6 is an inflammatory marker that's highly associated with endometriosis. And so we can test you for endometriosis without surgery, particularly if you have had recurrent implantation failure. That is one of the things that we would do. What happens if we find out it's positive? Well, then we suppress the endometriosis with medication. And that is 60 days of medication, 2 months of either Lupron to turn the hormones off, or there's a pill, one of 2 pills that you can take. One's called Orilissa and the other's called Myfembry. And these will both kind of shut down the hormonal supply to endometriosis and suppress that function of BCL6, which is inflammatory and is maybe preventing an embryo from implanting. So, Amber, there's your answer. Yeah, man, I would do it all. Absolutely, I would. Let's see who else has joined us here. Sharmila is here. Hey, my friend, nice to see you. I believe you are 22 or 23 weeks now. My embryos are at another clinic. Can I transfer them to your clinic? Is your current IVF clinic the same in terms of finances? So anyone can transfer embryos to our facility at New Life Fertility. The pricing structure in this facility is different than it is at CNY. We are predicated on, this is a kind of a boutique type practice where you get very close attention, close monitoring from the doctor and all our providers for the entire cycle. So a little bit different than some other places like Sharmila where your embryos are. But yes, we are happy to take your embryos, and I would love to help you get pregnant again. after you have this baby. So do this one first, and then we'll cross that bridge later on. Can't wait to see your baby pictures. Hey to Britt and Abel and Tony, nice to see you here today. Audrey is here. Brina Cruz, Olivia, Mary June, thanks for being here. And let's switch back over to my Instagram side and see who we've got here. Julep440 says, is Cunol a good CoQ10 brand? Is powder or capsule best recommended? Okay, so let's talk about CoQ10. CoQ10 is an antioxidant, and it has a function in the body of providing energy supply to your cells, particularly to the portion of the cells that are known as the mitochondria. So it's an energy supply. It's like putting gas into your cells. Well, as we mature, our CoQ10 levels start to go down. And that may be one of the things that contributes to diminishing egg quality as we mature. And so if that's the case, then if we take some extra CoQ10, we may be able to do an awful lot for our egg quality. And the answer is, yep, that's true. CoQ10 is probably the most important supplement that you can take for egg quality. I would take your prenatal vitamin for sure. That has folic acid in it, which you definitely want to be on folic acid. They say for 3 months prior to conceiving, 100% be on your prenatal. If you were going to take one other thing, and really honestly, there are 7 things that are on the evidence-based protocol for egg quality. But if you were going to take one other thing, it would be CoQ10. Okay, so now how much CoQ10 do you take? Well, there are 2 forms of CoQ10. One is called ubiquinol. The ubiquinol form is the form that is most bioavailable to us in the body. Ubiquinol is, if you're going to supplement with CoQ10, it's 400 milligrams a day of ubiquinol divided into 2 daily doses. So that's 200 milligrams twice a day, once in the morning, once at night. There is another type of CoQ10, and that is called ubiquinone. Ubiquinone is what's known as the oxidized form of CoQ10, and it is not the type that exists in the body, but can be used in the body. Sometimes it may be less expensive, or you may just pick up a brand and find, oh, this one's the ubiquinone instead of the ubiquinol. If you're taking the ubiquinone form, you want to be on 600 milligrams a day, and that's 300 milligrams a day in divided doses. So 300 milligrams in the morning and 300 at night. Julep, I usually find that taking a capsule is easier than using a powder. A lot of times the powders are gross. You have to mix them with something and it's chalky or it has a bad taste and you have to eat. You have to, kind of try to choke it down. So to me, I don't particularly like doing things that are powders. I would absolutely prefer the capsule. So Cunol is a brand of ubiquinol, and so it is completely fine. And as long as you know 200 milligrams twice a day is the dose that you need. So best of luck to you there, my friend. Oh, let's see who else we have here. We've got, we said hi to Heather. Kelsey is with us. Darcy is with us. Jay Serrano is here. Hi to Karen. I've IVF done my best. Love that handle there. Hi, Lisette. Hey to Dean. I'm sorry, that's Deanna. Rose. Oh, Rosa, I haven't seen you for a very long time. It's very nice to see your name again there, my friend. Hello to Zenny in Miami. Rosa says, and really, I would say it is wonderful to see you again. 42 years old. You're on Prograf. Oh, you're 11 weeks now. Well, that is, Rosa, that is fantastic news. I can't tell you how happy that makes me. When is it safe to stop Prograf? I have proteinuria on it. I have endometriosis and I suppressed with Orilissa. So usually about 12 weeks 12 weeks is the time that we say, by the time you're finishing out the first trimester is the time to go ahead and stop the Prograf. Now, the Prograf or tacrolimus was also studied in people who have what we call a poor obstetric history. And the poor obstetric history means that you got pregnant, bad things happen, like your membranes ruptured at 16, 17 weeks, or you had a preterm delivery at 19 weeks, or an abruption, or something not good happened in a prior pregnancy. Well, there is some evidence to suggest that tacrolimus may be beneficial in inhibiting those things from happening if you have that history. But I would not say I want you to be on that medication throughout your pregnancy. So I would go ahead and stop it at 12 weeks. Proteinuria means that you have protein in your urine. And you might say, so what? What does that even mean? Well, the kidneys are your body's filter, right? They're designed to filter out your blood. And think about it like this: they have a system that does this. So good things are supposed to stay in the blood, while toxins and extra fluid kind of is able to go through that little membrane there, and that's how it's passed out as urine. Protein is one of the things that generally stays inside the blood. When you have proteinuria, that means that little filter has become too loose and is allowing protein to spill through its little openings. I don't know that is a side effect of tacrolimus. That's not something I have heard of before. If it is, then when you stop it, that should go away. And I would say it's probably reasonable time. If it's causing you something untoward physically, then it's a hard sell to say, hey, you stay on it for an extra week. I'd go ahead and stop it. Now, some people have issues with their kidneys where they spill protein anyway. So that could be a kidney thing. So I'm not sure how we know that it came from the tacrolimus there, Rosa, but gosh, congratulations. What great news. It is so wonderful to see all my old friends here with us. Ask your questions right here, Fertility with Fink, or send them to me by email, and we'll get to them for next time. And that is Ask Fertility with Fink at firstfertility.com. It's about half past the hour. We'll be here for another 30 minutes. I am Fink. You are friends. And speaking of friends, the one and only Jody Hoffman has stepped up to the plate and actually turned on her Instagram. Jody is a nurse extraordinaire now living in Missouri. And miss you, Jody. Thank you for being here. Hey to Natalie and the Styles family. CC, aka Pinky says, is alloimmune test, which to my understanding, to see if my antigens fight against my husband's antigens. That might be a cause for the embryo dying off. Is that a test you would do in an IVF protocol? Well, there's not really a good test to be able to see if there is something that's called an anti-sperm antigen, which is probably a little different there. Pinky, if I may call you Pinky, there's not really a good test to say, hey, is your body trying to fight off your husband? Now, you may be trying to fight off your husband, but at the cellular level, is that really happening? We don't have a good test for that. And usually if we did, that would be an issue of the egg trying to prevent the sperm from being able to get inside. And with IVF, we are able to overcome that because we place the sperm right inside. We bypass that process in nature, which is where the sperm does something called capacitation. It's where the little head of the sperm develops its ability to pierce through the shell, if you will, of the egg and fertilize it. So we do that part for you in IVF, and I would think you'll probably be in a pretty good spot there. Now, there are some other things that we look at, some testing. Pinky, for example, we look to see. I thought what you were talking about there was blood antigens. So you know how people are A positive, B positive, O negative, AB negative, all those things. The positive and negative part can make a difference, but usually not so much a difference in getting pregnant, but rather sometimes in staying pregnant. And so the issue with that is that if you are Rh negative and your partner that provided the sperm is Rh positive, then you may create a baby that has an Rh positive blood type. And if that blood gets into your system, because it does, obviously you trade blood with your baby. It kind of flows through the whole system when you're pregnant. But especially if something happens to you, like you start bleeding, or you have a delivery. In the delivery, well, there's a lot of blood being exchanged. So if the baby is Rh positive and you are Rh negative, being exposed to those positive type um, those positives all kind of floating around in your bloodstream can result in you having a problem with subsequent pregnancies. And that's the reason that we use a medication that's called RhoGAM, or Rh immune globulin. RhoGAM is for women who are Rh negative. You will get it if you bleed in the first trimester, and you will also routinely get a shot of it at about 28 weeks pregnant. Then, when the baby is born, we test the baby's blood type. If the baby's blood type is positive, we recommend that you get another shot of the Rh immune globulin. If the baby's blood type is negative, then that blood being exposed to yours is not going to create an immune response. So that's what's called Rh isoimmunization. And I thought maybe that's what you were talking about there. Hey to Brock and Grace Tongue. Nice to see you and to see a baby in your world. Thanks for being here. Hello, Dr. Pena in Miami, and Tracy Castillo. Thank you for being here, my dear friend. Also in Miami. Annika, nice to see you. T. Andres. Let's see, Runner Girl Training. Hello, Kaylee. Thanks for being here this afternoon. I will tell you, Kaylee Gordon is the wonderful nurse practitioner here at New Life Fertility in Pensacola. And she is fabulous at what she does. She is a wonderful care provider, but she's also a caretaker. She takes her time with people, and really very impressed with Kaylee. She makes you feel very special when you are under her care. So feel good about that. Hi again to Sharmila. Erica, Blaxican Beauty. Hello, my friend. If a person has Hashimoto's and a low AMH, can they go for IVF? And what are the precautions to be taken of during the IVF cycle? So Hashimoto's is an autoimmune thyroiditis. The thyroid is the gland that lives in our neck right here. So if I were going to feel your thyroid, I'd walk around behind you and put my fingers on your neck like this, and I would tell you to swallow. And you go, you don't have to make the noise, but you swallow. And what that does is that it moves that thyroid gland under the fingers so I can feel its size and I can tell if there's anything growing on it. The thyroid is it's pretty common to get nodules on the thyroid, and that's where it works itself up into these little balls in the thyroid. Most of the time, these are benign. There are some specific criteria we use when we go to look at thyroid nodules, but some people develop an autoimmune response against their own thyroid gland. And that's what's called autoimmune thyroiditis. And it has a name. It was named by a doctor or a professor, Hashimoto. And so Hashimoto's thyroiditis is a condition that is autoimmune in nature. And it is something, Sharmila, that we address in IVF. So when you have Hashimoto's, that tells me that you've got an immune response to something, which means that we want to do something to try to cool down that immune response. So a lot of times we will consider using steroids in someone who has a history of Hashimoto's. And usually we like to keep the TSH level, which is the function of the thyroid gland. TSH is the thyroid stimulating hormone. Like to keep that around 1. So if your TSH is, let's say 2.8, and you have Hashimoto's, which is diagnosed through a blood test that's known as the anti-thyroid antibodies. So let's say that you've got anti-thyroid antibodies, and we find that in the blood test, your TSH is 2.8. We're going to give you a little thyroid medication because we want to treat that. The thyroid just functions better. Many studies say that fertility is higher when we treat Hashimoto's when folks are trying to get pregnant. Now, I will put a caveat there that some people don't treat that, and that's a choice because, again, the studies are not unequivocal that the outcomes are better, but in general, I think they are, and that's my read of the literature, and it's very easy to treat that condition. Now, if you're not trying to get pregnant and you have Hashimoto's, a lot of times the folks with Hashimoto's don't feel well. You may have symptoms from Hashimoto's. In fact, there's a really interesting website you might be familiar with that's called Stop the Thyroid Madness. And there's actually a book by that title. And the author goes on to try to demonstrate how many symptoms can be associated with Hashimoto's and with thyroid dysfunction. Well, and I agree with that. So in general practice, personally, when people aren't feeling well and I find they have Hashimoto's, I treat that because I do think it makes people feel better. Usually we use a different type of thyroid for that. That's called desiccated thyroid. A little bit of a different story there. But the problem is that thyroid dysfunction, symptoms of, well, let's call it hypothyroidism, are they're pretty vague, and they can be associated with lots of just general things of not feeling well. You may be tired. Well, we're all fatigued. You may be constipated. You may be gaining weight. Your hair may be changing. In hypothyroidism, everything is slowing down. The thing is with Hashimoto's is that sometimes it slows down, and then sometimes it speeds back up, and then it slows down, and maybe it speeds back up. It may be vacillating, going back and forth between being too slow and too fast. And so when we control that a little bit with some thyroid medication, we can do a pretty good job of trying to quell the thyroid's response to your metabolism. Now, the lower AMH is predictive of your response to IVF medication. Women with a lower AMH, and generally I say that's a number that's below 1, typically don't respond as well to medication. Does it mean that you don't respond at all? Absolutely not. Does it mean that you can't have a baby on your own? Absolutely not. It just tells us that, well, you may require a little bit more stimulation. You may need a little bit more medication. You might need a little bit longer, and that our expectation for the number of eggs that you may be able to produce with your stimulation is probably going to be a little bit lower. So lower AMH, absolutely you can do IVF. Hashimoto's, absolutely you can do IVF. Hi to Shada. Oh my gosh, it's great to see you on here with us. Sydney and Amber and SB Charles. Hey to Lauren. Shada says, oh yes, hello my wonderful doctor. Happy to see these Tuesdays back. Well, not as happy as I am to be here, my friends. Every Tuesday evening at 5 o'clock p.m. now Central Time, which would be 4 o'clock in the mountains and 6 o'clock on the East Coast. You can find me right here, and that's Fertility with Fink. Also, ask your questions here, or if you wish, you can email them in and we'll get to them next time. And then you get priority because we have them on a list on an actual piece of paper here, and that's Ask Fertility with Fink at firstfertility.com. Hello to Amber Vince in Kentucky, Toria and Amanda Morrison. Hey there. Hi, Jess in Dothan. Hey to V and to Greta. How long, Shada asks, how long is one round of 2-month Orilissa still good? Do you need to repeat it if the first transfer didn't continue and your next transfer may fall 6+ months after the end of your 2 months of Orilissa? So the question there is, well, what happens when I'm diagnosed with endometriosis and I suppress that endometriosis with my 2 months of medication? How long is that suppression good? I wish there was a definitive answer to that. Honestly, it really hasn't been well studied. My feeling is that it's about 6 months. And so at the 6 month mark, I would really want to think about suppressing again before doing another transfer. You know, my thoughts and prayers are with you, Shada. And in your case, I probably would think about doing another 2 months of suppression if you can. Jazzy Poo is here and a Princess Love. Hey to Mayfer and Amber. Oh, there's Amber. Thanks, Amber. SB Charles says 8 eggs retrieved, 4 fertilized, then 2 good, then 2 not so good. Why is this? Awaiting to transfer. Any advice for success? Should I take CoQ10 through the transfer? So we got a couple of different things going on there. So the first question is what to do for embryo transfer, because there may be other folks watching who are thinking about doing an embryo transfer, who are planning to do an embryo transfer. And the answer is yes, there are some things that you can do for that. 5 things to be precise. There are 5 things on the list that are evidence-based supplements to use that are said to improve embryo transfer outcomes. So number 1 is your prenatal. No kidding. We all know, you don't need me to be telling you now that you should be taking a prenatal. Prenatal is number 1. Vitamin D, vitamin E, CoQ10, and L-arginine. Now, the first 4 of those things you may have been on for your stimulation. They are part of the evidence-based protocol for STIM. By the way, if you want to know more information about, I keep talking about these evidence-based protocols. I have written an ebook on that. It's $7 and it gets you probably a $25 discount on the supplements if you choose to buy them through a site that there's a link in the book. But you can get to that ebook by looking at my link tree. That's linktr.ee, linktree/ Randy Fink MD, linktr.ee/Randy Fink MD. And there you can see the protocols for fertility, for IVF, for egg quality, for diminished ovarian reserve, as well as for embryo transfer, also for sperm, for endometriosis, and for PCOS. So those 5 supplements, SB Charles, I want you to be on all of them because they're easy to do and they may make a difference. When do you start them? I'd start them if you can a month before you're going to do your transfer. If worst case scenario, you start them in the cycle that you're starting to do your transfer, I think that's okay too. But if you can start them a month before, I think that's probably the best idea. Should you take CoQ10 through the transfer? And the answer is yes. I would stay on it really until you get your positive pregnancy test. 8 eggs retrieved, 4 eggs fertilized, and 2 of them were good. So that's really going to depend on age. Age is going to be the number 1 factor that gives us a statistic on how many of your eggs will fertilize and how many of them will continue to grow. It has to do with egg quality, which means the stability of the DNA, the genetic material that's in your eggs, that obviously goes down over time. So as we mature, the genetic material loses some of its stability, and we're more likely to create embryos or create eggs that become embryos that have abnormal genetics, and those embryos typically don't grow. And I presume that's what you mean by not so good. Not sure if you tested those embryos. If you test the embryos, then a euploid embryo is an embryo that is chromosomally normal, whereas an aneuploid embryo is one that is not normal. So usually it's associated with age. Jay Serrano, hi Jay. HCG levels prior to stimulation came back at a 12 and a 17 and then dropped to negative, less than 5. Was that a chemical pregnancy? And I think the answer to that is probably yes. So this was prior to stimulation, meaning to say you weren't taking any medicine, you weren't doing anything, you're waiting to start your stim, and surprise, surprise, you got a low positive beta. Yep. I'd say that's what we call a biochemical pregnancy. What is a biochemical pregnancy? There's two types of pregnancies. One is what we call a clinical pregnancy. And the clinical pregnancy is when it grows to the point that we can place an ultrasound in you or on you and see that pregnancy inside your uterus. That's what's known as a clinical pregnancy. A biochemical pregnancy is where the pregnancy test is positive, but it's still too early to be able to see that pregnancy on the inside. We often see these pregnancies with very low numbers like that, 12 and 17. We expect to see the beta HCG double in 48 hours. So the fact that that went from 12 to 17 said, well, you know what, it really isn't doubling there, probably not a normal pregnancy. And I would tell you that this happens more often than you would even imagine. In fact, it's said that most human conceptions end in miscarriage. And most of these miscarriages happen before people even realize that they're pregnant. So, Jay, if we hadn't been testing your hormones there, you may not have ever known that that test was positive, because with a beta of 12 and 17, your urine pregnancy test was likely to have not been positive. You probably need about a 40 or so of a beta before the pregnancy test, urine pregnancy, starts to be positive. So, that probably was a chemical pregnancy there. Shada says, check out Dr. Oh, thank you, Shada, for the little advertisement there. Check out Dr. Fink's bio for the link tree on the Vitamin Victory Guide. Thank you. Appreciate that. Kauser says, can I take Myo D-chiro-inositol? Ooh, that's a very good question there, my friend. So inositol is a supplement that is used to help with ovulation and with egg quality, particularly in folks who have insulin resistance, which is also the cohort with polycystic ovarian syndrome. So that's the most common time that we think about it. Sometimes we can also use these in folks with diminished ovarian reserve or with poor egg quality. There's some evidence to show that it may help in that scenario. The medication form of that is metformin. The supplement form of that is myo-inositol. So you're asking about something called D-chiro-myo-inositol. If it is just D-chiro-myo-inositol, I would tell you don't take it. It actually worsens egg quality. But there is a brand of inositol that is a 40-to-1 mixture of D-chiro-myo-inositol to just myo-inositol. And that you can take because theoretically, that's the ratio that you have it in the body. That brand is called, I'm blanking on what it's called. I am completely, because you asked me, I'm completely blanking on what it's called. There is better evidence on myo-inositol itself, by itself, instead of in this 40-to-1 ratio. But a lot of times people will say, oh, they told me to be on inositol, myo-inositol, and here's something that says D-chiro-myo-inositol, so it must be even better. I'm going to take that. Well, that one actually has been shown to diminish egg quality. So I would say that's a no-no. But if it's in that 40-to-1 ratio of D-chiro-myo-inositol to just myo-inositol, then yes, it is okay to take. Let's see. Rosa says, nice to see you. Sonia, Lisa, Devo, Tori is here. Hi, Tori. Fingers crossed for you, my friend, for sure. Kauser says, I have Hashimoto's, which we talked about a moment ago, and a positive ANA. I'm taking prednisone, low-dose naltrexone, doxycycline, baby aspirin, Prograf, are these meds enough for my transfer? And I would say, in all probability, the answer to that is yes. Looks like you're pretty well covered there. Not knowing anything else about you, but the ANA, we don't really know what that means. But given the Hashimoto's, I would say, yep, you're on a pretty good immune protocol there. How long after a miscarriage can one get a second transfer? Really, honestly, once you get back to having a regular period, back to having your regular cycle, then you absolutely can go ahead and do a transfer. Now, you want to make sure that you don't have a situation where there might be retained products. And I think a person asking this question may have had a run in with a question about retained products. So you want to make sure that the uterus is nice and clear. But once you've had that first period, you are fine to go back. Now, we used to tell people that we want you to give it 3 months, and that's after a spontaneous miscarriage or after a D&C. We'd always say this 3 months. Where did that number come from? Well, honestly, it was completely made up because there is no evidence to show that waiting is either helpful or necessary, but it may be both helpful and necessary for here more than down here, because your heart has to be ready to go through this process again. You know what it's like. You know what it's like looking at the calendar. You know what it's like getting to be at the right place at the right time to get an embryo placed inside, to use medicines or not medicines, and to do that monitoring and to have all these ups and downs and to ride this roller coaster only to wait and wait and wait and see if you get that positive beta. It takes a lot out of you. So I think more importantly than the physical aspect, because nature takes care of pregnancy losses. I mean, they do happen, unfortunately. It's cruel when it happens after IVF, probably much crueler than it is when it happens in nature alone. So I think when your heart is ready for you to move ahead, then the timing should be fine. Let's see, how many days with a 3-day transfer can I potentially get a positive? So usually by about, certainly within 2 weeks, usually by about 12 days or so, we would expect that you would probably have a positive. But remember, the urine pregnancy test is not nearly as sensitive. And so I don't encourage people to keep going out and doing urine pregnancy tests after an embryo transfer, because you may find that it's negative and you give up and you say, oh crap, this test is negative, this didn't work, and then you're really disappointed. And then just because you have to, you go get a blood test, and lo and behold, the blood test is positive. And you're like, what happened here? Just more roller coaster for you to ride. So I would say hold out. It's really hard. It's a really hard time to wait for that pregnancy test from the time of transfer. But I think emotionally speaking, you're probably better off, Tori, if you can. I've had 3 IVF. I've had 3 IVF ended biochemical pregnancies, and a doctor recommended that I take that test. Well, I'm not. That goes back to Pinky. I'm not sure which test that would be there. Hey, to Honey Girl. Here's a question about IVIG. IVIG is IV immunoglobulin. It's kind of the biggest gun that we have for the immune system. And we typically use it in situations where we don't know what else to turn to, where we've really tried every intervention and people either can't get pregnant or can't stay pregnant. So we really conclude that there is something in the immune system that's preventing that pregnancy from continuing, but we don't know what it is. So IVIG, or IV immune globulin, can be a really great thing. The data, of course, is mixed on it, but empirically, I'd say, gosh, I've seen miracles happen from it. The problem is it is super expensive. You have to get an infusion. It's just very, very expensive. Insurance most of the time will not cover it because it is, kind of considered experimental in that regard. But I would say, in some cases we do turn to IVIG. We've got a couple more minutes here. Let's see if we can't get to the last few questions. Actually, I'm not sure how many more questions there are there, but I'm going to try to get to them. If I don't get to your question today, please email it to me, and that's askfertilitywithfink at firstfertility.com. Would you know why it is not common to unblock fallopian tubes surgically? Heart arteries get unblocked all the time. Oh man, that is a really great question. Well, so when we unblock the arteries in the heart, we're doing that because we're trying to increase the blood flow that's going to them so that the muscle of the heart is getting the oxygenated blood it needs to stay alive, right? Because when that blood flow gets blocked, that's what causes a heart attack. So, why can't we do the same thing with a fallopian tube? Well, because the fallopian tubes are really much smaller. When we're unblocking a blood vessel in the heart, they're pretty big, fat blood vessels. And being able to return some flow of blood to that muscle will be good for that muscle. The problem is when fallopian tubes are damaged and they become blocked, then something on the inside of those tubes stops working, which means that even though we may be able to kind of try to roto-rooter a tube, as it were, so that sperm can still meet egg, there is a dramatically high risk for the embryo, once it gets fertilized, getting stuck in that tube and creating an ectopic pregnancy, which is a life-threatening problem, or can be a life-threatening problem. So certainly having a blocked blood vessel in the heart is a life-threatening problem. But the difference is when we have other alternatives to getting you pregnant that don't create that same amount of risk, that tends to be a better option. So the other thing there, Jay, is that unblocking the tubes can also not only increase the risk of ectopic, but sometimes it just simply doesn't work. And so then you're really talking about doing an essentially elective surgery for something that just may not get you where you want to go. Folks, gosh, we are out of time for tonight, unfortunately. So I am so glad you were able to join me. Please join me next week at 5 o'clock Central Time, 6 o'clock Eastern, and that's 4 in the mountains for Fertility with Fink. Remember what I always say, it was on my post from today. This fertility business is not the business of your life. It ain't your novel. It's not your book. This is just a chapter. And what are we here to do? We are here to rewrite that chapter together. So every step forward with kindness to one another, every step forward with love, one foot in front of the other, my friends, because tomorrow is a new day with all new adventures. And I can't wait to be a part of your tomorrow. So until next week, I'm Dr. Randy Fink in Pensacola, Florida. Thanks for being here. See you next time. Good night. Bye.